Shoulder impingement is commonly used as a diagnosis for shoulder complaints, and I don't agree with the pathoanatomy or pathophysiology kind of idea behind shoulder impingement. I'm not the only one with this thought process. We have evidence that the impingement tests are not really helpful or useful. We also have editorials that I've remarked on before in different videos about how we need to reconsider all these rotator cuff tests that we've been using in the past. So I'm not alone in thinking that impingement is kind of a wishy-washy idea, but I firmly argue that it's not a diagnosis. Impingement, of course, is a word that I can get behind as a symptom. Something can feel like it's pinching. The question therefore becomes, what is pinching and why is it pinching? And for different patients, that's different things. Back in the day, I learned about primary and secondary shoulder impingement. We learned about things like rotator cuff problems causing it, or capsular tightness, or bony abnormalities in the acromion like bone spurs. And all those things may be part and parcel of the patient's complaint. But again, as this kind of understanding that many things misfunction or misfire and cause the shoulder to move in a way that the head of the humerus is hitting into the acromion and causing impingement, I just don't buy that. And I think if people do read the literature and see that this kind of idea is not very sturdy, I think they still cling to it because they don't have an alternative. And that's what has really solidified my understanding of so many of these diagnoses that I learned not being real, authentic, tried and true diagnoses, is that I have an alternative. And the alternative for me is using repeated movement testing as a test and finding that so many patients' shoulder complaints can be reversed by moving the affected joint in the neck, in the thoracic spine, or in the shoulder joint repeatedly in the direction it needs, maybe 2 directions, and then all the shoulder complaints go away. If you don't have that paradigm, then you're going to abide by this idea of shoulder impingement as a diagnosis, and you're going to do kind of what we learned in school, which is like doing everything. And to me, doing everything is basically treating signs and symptoms and hoping for the best. Again, I've talked about this before, but you're going to be stretching the front, strengthening the back, maybe stretching the capsule, doing some PNF, doing some stabilization, strengthening the rotator cuff, doing some kind of motor control exercises, and then maybe the therapist will also do joint mobility, but not repeatedly in a specific direction, maybe twice a week or maybe in lots of different directions. So this book looks at, the usefulness of orthopedic tests. This is from 2013. Chapter 6 is on the shoulder. It goes through 16 tests that look for torn rotator cuff / impingement, and it looks at 7 tests that are just for shoulder impingement. I don't really understand why rotator cuff tests are lumped together with impingement tests. I don't get it, but I guess that's because I don't really understand or agree with the impingement as a diagnosis. But I do believe we have rotator cuff problems. The rotator cuff, of course, is 4 muscles, so we have to be more specific. You don't just say I have a thigh muscle problem. Is it the hamstrings or the quads or the gracilis? What is the problem? Which muscle and what is the problem? So a rotator cuff disorder usually is a supraspinatus tendinopathy, but it could be another one of the muscles. It could be in the tendon. It could be a tear. It could be a tendonitis, something acutely inflamed. So I don't understand that lumping together, like I said. But this book, the genius of this book is they go through, is there evidence for these tests that we use? And of those 23 tests that focus on impingement, only 1 gets a grade of 1. And they give grades based on the evidence for the test. And 1 would be strong evidence for the test. And that test in this one is the external lag test, I think, for a supraspinatus or infraspinatus tear. And that makes sense. I mean, if a muscle is not able to hold up the arm in a certain direction, it can be useful for diagnosing a tear. But all the other ones get lower grades, 2, 3, or no grade at all, meaning they have moderate, weak, or no evidence for use in the clinic. Again, when I use another paradigm for understanding the shoulder and understanding the body in general, I just don't see these vague ideas that so many things need to be done. I see very concrete things. That's helpful that it's so concrete because it's visible. We can see it. You move your neck into cervical retraction about 60 to 100 times per day, and 3 days later, your shoulder complaints are markedly improved or gone, or retraction extension, or cervical side bend, or shoulder functional internal rotation. As I've shown in videos before, the top 3 directional preference movements, the top 3 movements that fix shoulder mechanical joint derangements are repeated shoulder extension, functional internal rotation, and horizontal adduction. All of those typically with overpressure. But I just want people to know that there's other orthopedic ideas out there besides kind of these mainstream ideas about impingement. I do like the word impingement as a symptom. I just don't like it as a descriptor or definition of a diagnosis. I think you have to be more specific. Yes, for a rare few people, usually older, are there bone spurs on the acromion that are causing that pinching sensation? Yes, but I would argue that for something structural like that, in the majority of those cases, we're not going to fix that in my office. If the bone is truly a problem, the bone needs to be addressed. But if the tendon's the problem, let's go after the tendon. Supraspinatus tendinopathy, which I mentioned before, that management for that condition is very different than how I would address a mechanical joint derangement. Yes, it's still kind of repeated, but not to the same extent. And we're going to be putting load to that tendon so that we produce the symptoms that don't linger afterwards. And just like tendinopathy of the Achilles or patellar tendon, we're going to be loading that tendon to remodel it. So again, please consider that there are other diagnoses out there that aren't mainstream, myself included as one of the clinicians who abide by them. I find almost all shoulder complaints are either a mechanical joint problem in the spine or the shoulder, or a tendinopathy in the supraspinatus. Yes, of course, I've seen a couple frozen shoulders even in the last year. Those exist, but we have to kind of question this idea of posterior impingement, anterior impingement, all these different kinds of impingement. Would I only ever go there? I would only ever go there if I've ruled out with repeated movement testing that it's not mechanical, we've ruled out that it's not a tendon, and we just can't seem to grasp what's going on. Then I may look to one of these more kind of esoteric diagnoses to see if I'm missing something, but that hasn't happened to me with the patient with shoulder complaints recently. I allow that medicine and orthopedics can be complex, but for the average person, look for a mechanical problem for your shoulder complaints. If not, look for a tendinopathy that can be remodeled, and don't necessarily start on this impingement pathway, which is lots of different treatments over a rather relatively extended period of time.